Everybody, I'm just going to give an introduction for Dr. Froehlich. It's been real impressive because Dr. Froehlich knows a lot of the people in our audience today, either having been worked with him at the University of Michigan and or they are patients of his. And so, and I worked with them for 40 years. Anyway, so he is a professor of internal medicine. He's assistant chair and of medicine for quality and innovation. He's director of the vascular medicine program at the university and created it here. And also is director of the university's outcomes research, clinical outcomes research and reporting program. He is also director of the Anticoagulation clinic at the university, and he started by getting an undergrad and his medical degrees at Dartmouth, and then did his residency at in the New York area, and associated with Harvard, and then he also completed a fellowship in cardiology and medicine, vascular medicine here at the university in the mid-90s, like 1993 to 96. And after that, he got a master's degree in public health through Harvard, and at the same time was the the vascular medicine program director there and part of the cardiology department. And then returned back here to us at the University of Michigan, and he has had a joint appointment with both vascular surgery and cardiology. He's on the editorial boards of the Journal of Vascular Surgery, Cardio Research, Resource Review Journal, and the Journal of Thrombosis and Thrombolysis, and is an ad hoc reviewer for the American Heart Association and American Medical Association and the New England Journal of Medicine. And he was past president of the Vascular Medicine Society. He's written 120 articles, 11 books, and we welcome him, and I'm so glad it's mutual that a lot of people know him clinically and or personally, and he's here to talk to us. Welcome.
Thanks so much. Thanks, Elaine, for the very kind introduction. So, and one of the highlights of my career here at Michigan was definitely working with Elaine Fellows, who's flat out the best nurse I've ever worked with. And I apologies to, because there's actually other nurses that I've worked with here, but Elaine was the I don't know what the right word is, the pillar, the foundation of the vascular surgery service. And she did things which nurses aren't even allowed to do anymore. She would, quite literally, I mean, she would round with the team in the hospital in the morning. She would come to clinic to see patients in the clinic, round with the team in the hospital. So she took care of patients in the hospital and out of the hospital simultaneously. They don't permit that anymore. So she really is one of my heroes, actually. So thanks for the invitation. So, and I know this is a mixed audience in terms of backgrounds and people who've had medical, non-medical, academic, non-academic careers. So I'm going to try and make this useful and focus mostly on anticoagulation. But I really want you to feel like you can ask questions. Just raise your hand. All questions are good questions. Because if there's anything that you're curious about, I can guarantee you there's someone else here curious about it. Or if there's something that I'm saying that doesn't make sense, I can guarantee you there's somebody else here who feels the same way. Or what I'm saying doesn't make sense. So it's important that you point that out to me and everybody else, okay? So please interrupt, please. I've tried to leave plenty of time, but fortunately I have a timekeeper here. No one gave her a weapon, which is too bad, So mostly I'm going to talk about anticoagulation, and that means, has anyone ever heard of anticoagulants or take an anticoagulant? Yeah, okay, so this is really, really common because they're very effective. But it's an issue because they also can be dangerous, and so they're not like any other medication, or not like a lot of other medications. They require a little bit more attention and thought. So I'm going to talk about some of the ways in which we use them, some of the times in which we use them. I'm not going to talk about anticoagulants themselves. I'm going to talk about how we should use them and how we should think about them, and some ways to be safe about taking them, okay? So they always require us to give disclosures. Before the pandemic, I would consult with any company that made anticoagulants who asked me, because I had 3 kids to educate. So, and I've received research funding from a number of organizations, and this actually doesn't list them all. Most importantly, I'm not a hematologist, so I don't really care how anticoagulants work, so I'm not going to talk about that. But I thought first we should start with a quiz. I want to see what you know first, okay? So just shout out the answers if you know, because there's 7 answers to this question. The question is, what are the 7 ways a batter can get to first base? I'm talking baseball here. So what was that?
Hit by a pitch.
Hit by a pitch. Say it again. Walk. Error. A hit. Exactly. Who said that? Are you a baseball player? You were. So that's the one. He's upstaged me here. That's the one nobody gets. So, because that's the one most people don't know about. So you can get a walk, I heard. You can get a hit, I heard. Error, I heard. Hit batsman. I don't know if I heard that. So you plug the batter, he gets first base. Fielder's choice. So technically that's not a hit. So if there's a runner on first, you hit the ball to short, and the shortstop gets him out at second, and you're safe at first, it's not a hit, it's a fielder's choice, because they could have thrown you out at first. Dropped third strike. I didn't hear that. So if the catcher drops a third strike, and then catcher interference, so you get the prize. So let's talk about anticoagulants. I'm going to talk about just a couple things. So, whoa, sorry if I don't break the microphone. So I'm going to talk about atrial fibrillation's the biggie, because it's really, really common. And it gets more common every day. Unless you get younger, atrial fibrillation is more likely to happen every day. And so I'm going to talk about, and that's the main reason we give anticoagulants in this country, in the developed world. So a little bit about why we give them, who should take them, and what the drug options are. I'm going to talk a little bit about heart valves, just a little, specifically valve replacements, because that's another reason we give anticoagulants. And then I'm going to talk about just a couple things to think about, like bleeding and what can make it worse or better. What do you do about stopping your anticoagulant? And other reasons we might give it. I'll just say one word about cancer and prevention of blood clots. Okay? So we'll start with atrial fibrillation. So what is atrial fibrillation? Atrial fibrillation means it's an electrical problem in the heart. Okay? So over here on the left is kind of a schematic diagram. These are the 4 chambers of the heart. And for this purpose, for this discussion, there's the upper chambers, the atria, and the lower chambers are the main pumping chambers, the ventricles. Normally, there's an electrical signal that goes through the heart, like a wave on the beach. And it evolved to do that because that way, as the electrical signal goes to each cell, it causes each cell to contract. So if it goes in a wave, the heart contracts in an orderly, productive, pumping way. It starts in the up here just because. That's the way we evolved. All the cells in the heart can discharge and contract by themselves. But for the most part, they will wait because these cells up here at the top go more quickly. And once they go, they discharge their neighbors, they discharge their neighbors, they discharge their neighbors, and this wave of electricity goes through the heart, a wave of contraction goes through the heart. The whole thing reboots, does it again, hopefully. And again, and again, and again. So what's happening in atrial fibrillation is these upper chambers, which are pretty well insulated from the lower chambers except for one pathway, these upper chambers have just gone into complete chaos electrically. We thought for years and years and years there's no pattern, there's nothing we can figure out that causes it, it's just all chaos. And if you looked at it, what you'd see is quivering, because there's electrical signals going on simultaneously all over the upper chambers. So what does that mean for you and me? It means two things, mostly. It means a lot of chaotic electrical activity, so a lot of chaotic electrical signals are getting to this conduction to the pumping chambers. So chaos, irregular, and fast. So the heart can go too fast. So you can see in atrial fibrillation there are all these spikes when the ventricles contract. It's going faster and more irregularly. So that's problem one, heart goes too fast. Problem two, because there's chaos up here and it's not pumping, it's just doing this, little clots can form in the corner. That's a problem. Because then those blood clots could break loose and travel in the bloodstream and lodge somewhere important, or in your brain. So that, and cause a stroke. So those are the problems with atrial fibrillation, okay? Too fast, little blood clots. We can slow it down with drugs, and we can prevent the blood clots with anticoagulants. Does that make sense? This is why we give anticoagulants in atrial fibrillation. Okay? So that's atrial fibrillation. So that's the problem. But the answer in medicine as to why we do it is always about what does it help. So this just gives you an idea of the rising problem. So we're around here. This is the number of adults with atrial fibrillation in the United States. It's gotten to be about 3 million and is estimated to double by 2060. Because there's more and more of us, okay? Us being those less young. So, and the less young we become, the more likely we are to get atrial fibrillation. And more likely to have a stroke with atrial fibrillation. So that's the kicker. That's the thing, that's one of the messages I want to get through today is we're not only more likely to have AFib, we're more likely to have a stroke with it. And this is just from 65 to 75. It almost doubles the stroke risk. And it goes up, it continues to go up like that. So the older we are, the more we benefit from an anticoagulant. And that's sometimes tough for us to realize, and even our doctors, because they don't want to hurt people. So they're afraid to give a blood clot preventing drug to someone who's older, who's more likely to bleed. But we're also much, much more likely to have a stroke. So someone who gets atrial fibrillation, they need to have a blood clot preventing medication, an anticoagulant, an antithrombotic. And then the other questions are for you and your doctor to work on. How much should we try to keep atrial fibrillation away, and how much should we just rely on slowing it down so it doesn't bother us? And that's a topic for another talk. And a complicated one. I'm glad to answer questions, so please answer questions. This is just a list of the things that we really should, if we get atrial fibrillation, we need a good ultrasound picture of the heart and blood tests to make sure there isn't a cause besides getting less young. Other things are not necessarily, sometimes they're helpful, but aren't necessarily mandatory, like a stress test or a transesophageal echo to look inside the heart more closely for a clot. And so I'm not really going to go into that. Again, this talk isn't about atrial fibrillation. So in medicine, the question is not, okay, do we have a problem, blood clots and strokes with atrial fibrillation? But then the question is, what can we do about it, and should we? And these were landmark studies in the last century, all of them, that randomized people with atrial fibrillation to either an anticoagulant or nothing, and proved, excuse me, and proved that you could dramatically reduce the risk of stroke with these anticoagulants. So that's why. And then the next question is who? So this is one of the tools we use. These are the guidelines. This is the alphabet soup of cardiac organizations: American College of Cardiology, American Heart Association, the Society for Thoracic Surgery, the Heart Rhythm Society. Everybody has their own society. And so, but they all agreed that this tool is very effective in estimating risk of having a stroke with atrial fibrillation, because there are things that increase our risk. One is age. So if you're over 65, you get a point. If you're over 75, you get 2 points. And other things that turn out to increase risk of stroke: hypertension, diabetes. So if you develop atrial fibrillation, this is what your doctor will look at. Why? Because the score you get based on these risk factors directly relates to the risk of atrial fibrillation over here. So the risk, if you have a 1, your risk of a stroke is only 1%. But if you have a 5, your risk of a stroke is almost 7% per year. And so that's what these people at higher risk, if you have diabetes, if you have hypertension, if you have heart failure, if you're over 75, your risk is high enough that the benefit would be worth it to take an anticoagulant. Make sense? And then some of you who have taken warfarin will realize, because you probably heard this a million times, and someone in the audience was kind enough to come up and say, yeah, I get calls from your nurses all the time. This is the INR, which is a measure of how well the warfarin or anticoagulant Coumadin is working. And the dotted line is the risk of bleeding, and the solid line is the risk of a stroke. And you can see the middle range here, from about 2 to 3, is where stroke risk is minimal and bleeding risk is minimal. This is a study done by Dan Singer at Mass General, and it's observational data. He just looked at thousands and thousands of people on Coumadin, and it turned out to perfectly support what we've been doing for years. And that is trying to keep the INR measure of warfarin effect between 2 and 3. Does that make sense? So I mentioned 2 slides ago the risk of stroke is related to this score based on your risk factors. We call it the CHAD score. And as with almost everything in medicine, the higher your risk of a problem, the more you benefit from the treatment. It seems logical, but we don't always think of it that way. So not everyone with atrial fibrillation gets the same benefit from warfarin anticoagulant. The higher the risk, the greater the benefit. So again, the more risk factors you have, the more you benefit from taking that anticoagulant. And then the next slide shows that that's true specifically for the problem of age. Did I say age was a problem? I meant the feature, the aspect. So personally, I'm not a fan. I think I'm not sure that aging is a really good idea, but because I'm not enjoying this process entirely. But I really enjoyed that first talk, I have to say. I thought she was wonderful. I'm so proud to learn about colleagues like that who I work with that I didn't know. I think I got to go to her website too. But this just shows that the greater your age over here, 65, 65 to 75, 75 to 85, the greater your age, the more you benefit from Coumadin or warfarin. And that's an important concept because as we get less young, we are more likely to bleed. But without warfarin, we're much, much more likely to have a stroke if we have atrial fibrillation. Does that make sense? So I think these are important studies to understand, to help you and your physicians understand the risk versus the benefit of any drug. And anticoagulation, as I said, is a two-edged sword. It does have risk of causing bleeding. And we are more likely to bleed as we get less young. So I've talked about warfarin a couple of times. As probably everyone here knows, that we now have other options for anticoagulation. And these are some of the data that were generated when those drugs came out that show that they are, and many of them are as good or superior to warfarin. So this was a test of the drug dabigatran or Pradaxa. That was the first of the alternatives to be introduced. And this study, I didn't put the date. I'm trying to remember when this study was. Almost 20 years ago, probably. And they compared 2 doses of dabigatran, high and low, with warfarin. And this is a risk of stroke. The low dose was just as good as warfarin. The 2 lines overlap. This is the number of people getting a stroke over time. And the high dose of dabigatran was actually significantly more effective than warfarin. So this was a revelation, because we had previously been using warfarin for 60 years. One of the first most famous patients to receive warfarin was President Eisenhower. So most people didn't know, but he had a heart attack when he was president, and the doctors at the time thought, well, crap, we got to do something, and they gave him warfarin. It turns out they were years ahead of their time, because it wasn't apparent in the 50s that heart attacks were caused by blood clots. And most of you may know a heart attack is caused when an artery that feeds the heart gets clotted. And now we use a lot of drugs to dissolve clots or go in there and open the artery up. No one knew that in the 50s, but it actually was the right thing to do, given the technology of the time, to prevent more blood clots. Same thing for the other new drugs. This is apixaban, also called Eliquis. Anybody heard of Eliquis? Yeah. Do you watch TV? So it's on, and so what does that tell you? It's advertised all the time. That tells us it must be really expensive and profitable, right? So that was the problem. But this is compared to warfarin in AFib, much less stroke risk, and safer. So this has become the darling. As a cardiologist, we have little brains, and so we like to think, I just need one drug. Apixaban is the favorite of most cardiologists because it's been shown by this study to have less bleeding, and in the previous slide, fewer strokes than people on highly effective warfarin. So this just seemed like a no-brainer, right? We give it out like candy for people with atrial fibrillation. And then rivaroxaban or Xarelto, same thing. It's significantly more effective, and I don't have the other slide. So these are all effective alternatives to warfarin today. And what you end up taking depends on a lot of things that you and your doctor have to discuss, not the least of which is cost. That's still an issue now, 15 years on. So I'm going to harp again on age, because I think this is important. This again shows, this is the stroke risk. And as I said, if you take an oral anticoagulant, your stroke risk goes down. But if you're over 85, it goes down a lot if you take an anticoagulant. So again, the older you are, the more you benefit, but you don't get hurt more. And that's what physicians are often afraid of. If you're less young, you're more likely to bleed. And so that's made us physicians think, oh, I don't want to give them something that causes bleeding, right? But you're not more likely to bleed with the drug. And that's what this showed. So people under 85, about the same amount of bleeding. People over 85, about the same amount of bleeding, with and without the drug. More, but not really more with the drug. Just more because of being less young. Does that make sense? Yeah. Good question. I mean, thanks for saying that. So we're more likely to have all kinds of problems as we get older. And sometimes it's a problem that would be made worse by a certain type of treatment. So we're more likely to bleed just going about our daily lives. We're more likely to have a bleeding stomach ulcer. So, but that doesn't mean that adding an anticoagulant is more dangerous for us than someone who's younger. That is not true. It carries the same risk. Does that make sense? Yeah. Question?
Yeah, what's the difference between anticoagulant and taking something like low-dose aspirin, ibuprofen?
Good question. So her question was, what's the difference between an anticoagulant, like warfarin, like Eliquis, and taking aspirin, for example? So they both prevent clotting, but they do it in different ways. And we have referred to these drugs that I've talked about as anticoagulants because they interfere with clotting. Aspirin interferes with platelets. Platelets start a clot, but they're not part of the body's clotting system. So we think of them differently and we label them differently. We call them antithrombotics maybe. What we mostly call them is antiplatelet agents. And there are a lot of drugs that interfere with platelet function. And they are beneficial if your problem is clotting. But because they work at different parts of the way the body clots, they work better or worse in different problems. Turns out for preventing I don't know if anybody's heard about stenting arteries open. So if you put a stent in an artery, the stent can promote clotting. But the way it starts is with platelets clumping. So it turns out aspirin is the best thing to take if you have a stent to prevent clotting. You don't need warfarin, you don't need Eliquis. But that's just we know that just because of research that's shown that. They interact with different parts of the way the body clots. Does that make sense? And the platelets, just a second, and the platelets are how clotting starts when there's a problem, like a cut. So if you take aspirin, you're more likely to bleed. If you cut yourself, shave it. Yeah.
This might be getting into the weeds, but you said when you get older, you're more likely to bleed.
Yes.
Why?
Well, that's just because we're more fragile. It has nothing to do with the clotting system. It has to do with the fact that we're more likely to get stomach ulcers, we're more likely to fall. You may not have noticed, but our skin gets thinner, okay? You get bruises under the skin. It's not because you've been out fighting. Well, in your case, I don't know, but it's because we're more likely to bleed. There's less collagen in our skin. It's very, very thin. The blood vessels in it are easily broken, so we get bruises on our arms. And it's not because it can be made worse if you take aspirin, but even if you don't, we're more likely to bleed. And that is true for everything in our body. Even rare catastrophic things like a bleeding stroke. That's more likely to happen in someone who's 80 than someone who's 40, because the blood vessels in the brain are more fragile. So it's really just about systemic getting less young. Yeah.
You talked about atrial fibrillation, but you haven't differentiated between people who have a successful SAP and people that don't.
Yeah.
So what are your numbers referred to?
Yeah, that's a really good question, and that is the bane of my existence. So his question is, okay, you had atrial fibrillation, but you got cardioverted, you got shocked out of it. Or better, you got an ablation procedure, which is really expensive. And so it's got to be good, right? It's not a cure. So that's problem one. We don't know. The problem is neither of those are a guarantee. And atrial fibrillation comes back after both of them. Sometimes. And we don't know how to predict if it's gonna. And we also don't know, this is one of the biggest questions in cardiology, how much AFib is too much in terms of stroke risk? There's some research that suggests 6 hours is enough. You get an ablation, and in the middle of the night, you're asleep, you don't know, your heart goes into AFib for 6 hours, comes back out, you never know. That's enough to increase your stroke risk. So for a lot of patients, even though they've had a cardioversion, had an ablation, we recommend continuing these drugs. That's an individual decision between you and your cardiologist. In some cases, we might feel comfortable enough stopping it. This is a really good question to which I don't have an answer. And so in 2024, for the most part, if you've ever had AFib, you have to take an anticoagulant for life. Yeah.
You've been talking about the oral medications. What about the implants that they emphasize?
So implants for,
Anticoagulation.
yeah, so I'm not aware of any implants for anticoagulation. There are implants, heart monitors. We can use intravenous forms of anticoagulants. But there are no sustained release sort of options for anticoagulation that I'm aware of. I thought there was, yeah.
If somebody just,
Oh, sorry.
can we hold the questions for the end? And they'll be using a mic so that everyone can hear the question?
Yeah, so the other thing we could do is, how many mics do we have?
2.
This one and that one?
Mhm.
Okay, can I? Oh, good, so, we have another one. Okay, great. So what I'm gonna do then is, can you hear me? Okay, so I'm gonna walk around, and so I would like to encourage questions if it's okay, if I can get a mic to people.
So we normally have the last 10 minutes for questions.
Okay.
But if this works better for the group, Sandy
Well-
will just need to cue you in
Yeah.
that you have like 2 minutes left and the question and answer, or the whole presentation's over.
Yep, will do.
Okay.
But I do, sometimes questions occur and they don't, you're not gonna remember it later.
Right, and
Yes,
we do have
Roger.
people online.
In our YouTube, if you're not close to there.
I can't be seen. Well, then nobody wants to see me anyway. They just want to. I'm not much to look at. So I think as long as I can see the slides, this is the same thing. The older you are, the more you benefit. I'm going to skip that. But I already mentioned. I will keep my eye on the time. I promise. And I just wanted to mention in this slide some of the things that you and your doctor are thinking about when you are choosing anticoagulants. I already mentioned one, and that's cost, right? Another is kidney function, because different drugs are removed from the body by kidneys and some are not. Also, what the resources are for you and your physician in terms of managing it. I mean, we at the University of Michigan, I run it, so of course it's outstanding. We have an anticoagulation management service, and we help people manage their warfarin. And if you don't have that in your community, you may not want to take warfarin, et cetera. And then I'm going to talk about valves, and there's always drug-drug interactions concerns. With most drugs, there's lots. With warfarin, there's millions. It's just absolutely a nightmare. Oh, you have a microphone.
She
Go.
gave me the microphone, thank you. There's been a lot of promotion of the Watchman procedure.
Watchman.
And I'm curious about if you do obtain a Watchman, whether you continue the Eliquis or not, or
Good question.
aspirin or whatever.
Yeah, so explanation of the Watchman device. So this is another reason why I wanted to encourage questions, because atrial fibrillation is a nightmare. It's more of a nightmare in terms of complexity than danger. It's actually not that dangerous. I already talked about heartbeat too fast, stroke risk. Those are the dangers. So a Watchman device, remember I told you when the heart is fluttering, little clots can form in the corner. And there's a corner that's the culprit. And we've known this for years. It's called the atrial appendage. It's this little floppy cul-de-sac. And the flow gets really sluggish in there in AFib, and that's where clots start. So some entrepreneur thought, well, let's just plug it up. So a Watchman device is a plug that you stick in the atrial appendage. And when you put an artificial thing in the body like that, it will heal it over. And so it will actually close the hole. So we currently think, this is relatively new therapy, but it's not experimental, that if you get a successful Watchman device, you probably can stop anticoagulant. However, the key word is successful. In 2024, I think the state of the art is the newest Watchman and a follow-up ultrasound to make sure it has sealed. And we see leaks all the time. And then if there's a leak, we say, essentially, for the purpose of getting you off the drug, it's a failure. So yes, maybe. All right, so that's about atrial fibrillation. I'm going to switch now to the next quiz, Which ballpark in America has the shortest home run distance? So yeah, the majority got it right. It is Fenway Park. 302 feet at the right field pole. Here's the bonus question. What is that pole called? It's the Pesky pole, that's right. It's named after Roger Pesky. It happens to be the most beautiful ballpark in America, too. I'm not biased. So which ballpark has the deepest home run wall? Trick question. Yeah. So the answer is Fenway Park. In that little tiny cul-de-sac, there's a little corner, a cul-de-sac back there, because they were building it on a city street in 2012 or 1912, and they wouldn't move the street. In that cul-de-sac, it's 420 feet, and that's deeper than any other ballpark in America. So, yeah, just one of the many wonderful things about the Red Sox and Fenway Park. So, I'm going to talk about valves. So, what are heart valves? I showed you that picture before. They're chambers of the heart, and the heart valves are one-way doors, like saloon doors that can be pushed open when the blood is pushed against them, and otherwise they slam shut. And if there are 4 valves, 2 between the upper chambers and the lower chambers, and then the other 2 are between the lower chambers and the body. And problems can occur if those valves become damaged or break down, wear down with time, or need to be replaced for any reason. And because the problem is, so this is just a picture that shows, I'm not going to run the tape, but the blood comes into the right atrium from the body, head, body. It goes through the tricuspid valve into the right ventricle. When the right ventricle squeezes, it goes through the pulmonic valve into the lungs. It comes back from the lungs into the left atrium, gets pushed through the mitral valve into the left ventricle, and then out the aortic valve into the body. Does that make sense? So there's 4 valves. 2 are allowing blood into the heart, 2 are allowing blood out of the heart. The problem is, you don't really need to know all that. It just explains what valves are, okay? The problem is if they're abnormally shaped. This is a normal aortic valve on the left. It looks like a Mercedes-Benz sign, and you can see how it's easily pushed open and closed. But if someone has a so-called bicuspid valve, it's not normally shaped, or it becomes calcified and wears down with age, just like our knees get calcified, so do our heart valves, and then they don't move properly. And if that's bad enough, you need a new valve. It's a wonder that we can replace valves. It ain't a free lunch. And one of the problems is the artificial valves tend to clot. So I was just going to show you, this is a schematic, if you were wondering, if you've had it done. This is how we replace a valve. It ain't easy, okay? Don't try this at home. You got to get to the heart. Getting to the heart to start the operation takes 2 hours of surgery. This is a big deal because you've got to get to the heart without damaging it. You have to put all these tubes in it to bypass the heart and the lungs and then stop the heart. Then you can cut it open. At the root of the aorta, the aortic valve gets cut out and then replaced, either with a mechanical valve or a so-called tissue valve. They like to say, you know, like pig valve, but it's really tissue from some other animal, sometimes humans, sometimes pigs, sometimes cows. And this is what it looks like in the operating room. If you're squeamish, you can look away. But I just wanted you to give you a flavor. This is not a chip shot. This is something that requires a great deal of technical skill, an incredibly complicated team, not just the surgeon. You can see all the sutures. I don't know if you can see in this picture, all these strings. All of those strings are sutures that are going to hold that valve in place. And needless to say, they all need to be placed pretty carefully. This is a highly technically demanding procedure, and yet we do it every single day because we've been doing it for 60 years, and we got it down. Yeah? Question?
Some people have trouble with their blood
Yes? Some,
A lot of people have trouble with blood that doesn't clot enough.
right.
So how do you work with that?
Yeah, that's a really good question. So her question was, some people have blood that clots too much, and we call that a thrombophilia. Or some people have blood that doesn't clot enough. You've heard of hemophilia, right? They bleed too much. So there are many, many, many causes, and there's many, many degrees of severity. So suffice it to say, that's why I didn't become a hematologist, because I'm just not smart enough. And heart disease is pretty cut and dried by comparison. So the answer to your question is it's way beyond my ken, and it's really an individual decision. And it's based on how bad your clotting problem is, or how bad your bleeding problem is, and then even more importantly, what's the specific problem, and can we fix it? If you're missing factor 8, that causes hemophilia, we can now give you factor 8.
So do you work with hematologists or?
Do I work with hematologists? You betcha. On a daily basis, because they have the brains. And so we work together very closely, absolutely. And I take care of their patients who have clotting problems with our anticoagulation service. So really good question. You know, clotting is good, but too much is bad, and not enough is bad. And these are the pictures of the artificial valves to show you. They come in basically today 3 flavors. 2 mechanical valves on top. They either have 1 disc or 2. And then the bioprosthetic valve on the bottom. This matters because all of these valves are more likely to form clots. It's a feature of artificial things. Almost anything artificial is going to stimulate the clotting system. So if it's in your bloodstream, it's going to stimulate a clot. I remember I told you the stents will stimulate clotting. These valves will stimulate clotting. And so anticoagulants are often necessary. The mechanical valves are much more likely to cause clotting than the bioprosthetic valve, but they're much more durable. Lots of decision-making on an individual basis about what to do. And then today, so you may have heard of something called TAVR. This also is way past experimental. This is standard operating procedure. We can now replace the aortic valve of the heart without surgery, without that big complex operation I showed you. We can just stick a catheter, a plastic tube, into an artery in the groin, snake it up through the artery to the aortic valve, and crush it with a balloon, and put a new one on the bottom right, a new bioprosthetic valve in its place. Yeah, it's extraordinary. Patient is ready to go home in a day or 2. Yeah. But there's always new problems with these things, and one of them is clotting. Yeah, question.
You don't have all the strings, what holds it in?
So she asks, I don't see any sutures. I don't see any sutures. What's holding that in? There's an anecdote that I like to tell about that, and that is that this shouldn't work because of exactly what you said. And the cowardly would have said, well, we're never going to replace surgery because we can't get in there and stitch it. The answer is someone tried anyway, and it worked. And a lot of innovations in medicine are like that. The anecdote is one of the people who was in charge by the FDA to approve this device 25 years ago, or 20 years ago, he said, it's a little funny story. He said, you know, when an invention like this comes up, when inventions come up, you get a new app, you do this, you see a new invention, he used to always say, why didn't I think of that? Right? We've all had that. I could have thought of that. And he said, for this invention, I don't feel bad at all, because this shouldn't work. He said, I'm an expert. He's one of the world's leading experts on aortic valves. He said, I've spent my whole life carefully stitching these things in, and some of them still pop loose. Why does this work? It shouldn't work. But it does. So I don't actually have an answer for you. You know, someone tried it, and if you with the right material and the right amount of pressure against the wall, it sticks and it stays. And I can't tell you why. And I can tell you, however, it's so reliable, this is actually now preferred. It has better results than the standard operation. And whether or not you need this or the standard operation there are many things to think about. So, another question.
Yeah, how is AI gonna help you guys or not help you guys?
So she wants to know, how is artificial intelligence going to help? So I've been around long enough to see many innovations like AI come about. And my bet is it will help a lot, but in ways we didn't expect. And there's two different types of AI. Well, not two. There's different types of AI. One is the chatbots. All they're doing is randomly trying one word and then another. But computers have gotten so fast that they can try them all. And they can come up with sentences that make sense. That's one type of AI. It's the same with chess. There's no question anymore computers can easily beat people because they can try every single conceivable move because computers are so fast. So that's one type of AI. But then there's another type of AI where we give a computer information and tell it to learn and draw its own conclusions. And that has yet to, and it has to do with designing things like this. Because what I said in answer to Corinne's question was, they just tried it and it worked. It wasn't that simple. They tried lots of things, just like Edison. He said he invented 1,000 ways a light bulb wouldn't work, and to find the one that did. And that's the way we used to design things. AI will allow us to streamline that process. And you can feed into a powerful computer all the features of an aorta, a valve, its tensile strength, all kinds of factors, and say, what might work here? And then we don't have to invent 1,000 non-working light bulbs. So AI is going to change everything, but I don't know when. So I'm not going to go through all this. This is just for your own information. But all it says is, this is the way our guidelines look and help us to decide if I put a bioprosthetic valve in someone, do they need anticoagulation? And this helps us to figure that out. But some people are going to get clotted valves, and so they do. So I'm going to skip those details, and I'll show you this picture. So even the TAVR valve, that's the one I showed you that you can put in with a catheter. Even that valve is subject to clotting. And these are CAT scans that show little clots forming on that valve. And so, and that can be treated with an anticoagulant and get better. And that's a problem that occurs in some of these. I think I'm going to end with this last. I don't even know if this will play. Can you make that run? So before you start. So the question is, what happened here? And you can start it. Hopefully there's no sound. No, I don't want sound. So what happens is, the pitch is thrown, and all of a sudden, look at the umpire. He says, wait a second. Runner on second goes to third, runner on first goes to second. New ball, next pitch. So what happened? So the question is, can I advance? Okay, so what's the call? Was this a balk? It's a multiple choice question. Was this a ball? Was this a catcher's balk? And who knows what a catcher's balk is? Was this a catcher error? Or was it catcher interference? Who thinks they know the answer? Yeah, so it's actually not catcher interference, because that's when the catcher, the batter, he gets in the way of the batter. It's not a catcher's balk. Does anybody know what a catcher's balk is? So the catcher has a box just like the batter has a box. Catcher has to stay in the box when the pitch is thrown. If the catcher leaves the box before a pitch is thrown, that's a catcher's balk. You almost never see it. It's not a ball, because that certainly wouldn't get the base runners moving. And it's not a balk because it wasn't called on the pitcher, it was called on the catcher. No, you see in this picture, he moved the ball with his mask. That's an error. You can never touch the ball with anything but your hand or your glove. So that's an error on the catcher, and therefore the runners advance. Catcher leaves his box as the catcher's balk. But in this case, Christian Vasquez did not commit a balk. He committed an error by picking up a pitched ball with his mask. So I'm going to end there instead of, because we are almost out of town. I guess I would show this slide, because she's going to start yelling at me. We got 10 minutes to go. So when you are deciding among anticoagulants, there are a lot of things to consider. And in medicine, we try to rely on comparative research, right? I showed you those graphs of comparing warfarin with Eliquis, and the rate of bleeding with Eliquis was just less, head to head. The rate of stroke with Eliquis was less, head to head. So I can say as a doctor, Eliquis is actually better in people like the people in that study. Does that make sense? So I often get asked, well, should I take Eliquis or Xarelto? Should I take Pradaxa or warfarin? And for Pradaxa versus warfarin, we have those head-to-head studies. For apixaban versus Eliquis, we don't have head-to-head studies. But we have data like this. This is from a guy named Greg Lipp in London. And what he did was he looked at thousands and thousands of patients taking anticoagulants and compared what happened to the people taking one anticoagulant versus another in terms of bleeding in the orange and bleeding if they're taking a protective agent like Nexium in the blue. So the answer is Nexium, Pepcid, what's the other? PPI. All those drugs like Nexium are very good at protecting you from bleeding in your stomach, which is where most bleeding occurs. Omeprazole, I can't remember what it's called. Prilosec, thanks. But what we think we learned here is that apixaban actually causes less bleeding than Xarelto or Pradaxa. Now, they weren't compared head-to-head. This was just looking at thousands and thousands of Brits and seeing how much they bled if they took this drug or that drug. But this does help us this is one of the reasons why cardiologists love apixaban, because it just seems to have fewer complications and better efficacy. So those are the things that go into, I'm going to stop there, because this is all basically about the same thing. And I'll stop here with one last quiz. So anybody know who this man is? I'll give you his name, and then maybe you'll know who he is. His name is Theodore Geisel. That's right. This is Dr. Seuss. So why am I showing this slide? So Dr. Seuss went to my college, and so for whatever the usual reasons, they've named the medical school after him. The medical school, of all things. So I went to the Dr. Seuss School of Medicine. So I'm going to stop here, and I'll answer more questions. Roger.
Okay, question. You have to have AFib before you start this? I mean, it's like, do you have to worry about it now or after you've already had the problem?
So that's a really good question. Should I be worrying about this now? And the answer is maybe. Okay, so here's the problem. Okay, remember I said the problem with getting less young is, well, one of them, more AFib. So they did a study in Sweden where they gave a bunch of people who were over 65 a little EKG monitor. They could do their own EKG at home. Said, do your own EKG, 5 seconds every day. And then a bunch of controls didn't get the device. They found 4 times as much AFib in the group that did their own little EKG at home every day. 4 times. And when they found it, they started apixaban, Eliquis, and they decreased the stroke rate by 40%. Yeah. So there's a lot of atrial fibrillation out there that's getting missed. A lot. And many of my colleagues have said, this may be something we should just be screening for, like they did in Sweden with that study. The device is called Cardia Mobile, and you can buy it on Amazon for $90. Question with the microphone, sorry.
Sure. Any reversal agent for Eliquis on the horizon?
It's here.
It is.
Yeah, we have a reversal agent for Eliquis, for all of them. A different one for Eliquis and Xarelto than for dabigatran, but they both exist. They cost about $45,000 a dose.
That's why I didn't get it. Okay.
So we only give it in the, well, first of all, the drug is going to be out of your system in 12 hours. So we only give it for life-threatening bleeds, or someone needs emergency surgery and they just took their Eliquis. So we can do it. We've got it.
Okay. And throughout this, you didn't mention flutter. Is it a different talk next week, or?
Yeah, I'm glad to come back. So atrial flutter, for the purposes of anticoagulation, same. We think it has the same stroke risk. Next question.
Yes, the INR is good for the Coumadin.
Yes, ma'am.
Is there any test on the horizon to assess the level of Eliquis and
Don't need it.
therefore the dosage that should be used,
Don't need it.
other than the studies that relate to age and
Yeah.
blood level?
No, we don't need it. That's one of the reasons why it's better. So how many other drugs do you take? Do you check levels on? Warfarin's the exception, not the rule. But because it was our only anticoagulant for years, we feel like we're safer if we check the levels. The new drugs don't need it. They are very, very, very reliable unless you have kidney failure. They're going to be the same in everyone in the room.
Well, I understand that there's criteria in relation to age and weight for the dosage of Eliquis.
Yeah, that's only for Eliquis, and it's only because there was a bad idea. It really only has to do with kidney function. And so but the way they studied it was those three things: age, weight, and creatinine, which is a measure of kidney function. And if you have two of them were substandard, then their research showed them that your drug levels require a dose reduction. But you shouldn't really know about that because it's not useful information. But that's how it's one of the things your doctor uses. But the main thing is kidney function. That's the main issue. And they were just using weight and size as, plus kidney function to figure out how you're going to clear this drug. But almost everybody with normal kidney function is going to be the same.
Okay, thank you.
Yeah, good question. Yeah, so I'm going to...
Quick question, these wonderful watches, they tell you about your AFib from last week, this week, and it's all over the place, but I understand that that's not a reliable AFib measure, right?
It's not as reliable as the CardioMobile device. I don't get any money from CardioMobile, don't get me wrong. But because it was studied like that in Sweden, we can rely on it. This, not ready for prime time yet. Yeah, question with the microphone.
Well, actually, I'm going to go way back to the scoring. If you have AFib and you get credit for certain things like
Yes.
hypertension. I saw gender up there.
Yes.
Females, we get a point?
Yeah,
So we're
that's not a good thing.
I know. So I guess I was more curious about that because I saw a female up there and I thought, is it because we live longer? Why do females get an extra point?
Beats me.
Okay.
So that's all based on observation.
Okay.
Women are more likely to stroke with AFib. I don't know why.
So
If
my-
I knew why, I'd do something about it.
All right. So the second thing I wanted to ask about back in there is you kept talking about as we get older, we do better as far as the anticoagulation component. And it's because
You benefit more.
you benefit more. Is it because those of us, I'm not there, but are 85 or older, maybe we've done things differently? No?
It's not a good thing. It's because your risk is higher. Anyone whose risk is higher is going to benefit more
Okay.
from a treatment that works. If it works, it will be of more benefit to someone who's at higher risk. That's true for all of medicine. Yeah.
Okay, in relationship to that same chart that went from 1 to 9 in your risk, I thought I saw an anomaly where the numbers of your thing dropped down between 7 and 8, then went back up from 8 to 9.
No, that was if that's true, that was a typo.
Oh, okay.
No, there are no anomalies. It's definitely linear. Patrick.
So I've been on warfarin for about 15 years, And I told you earlier, Bo, and everybody here, your staff is wonderful.
Thanks.
It's great
It's all
calls
them.
from
They're
you, very
great.
helpful.
I agree.
Why haven't I been moved to Eliquis as some of these other options? I've always assumed it was cost.
It's not just cost. So this is a more complicated discussion. So I showed you head-to-head data for the people in that study. Eliquis may be better. But there are two things about that. One, you have to be one of those people in the study. If there's anything else different about you, then those data don't apply to you. And I don't, so that's thing one. Thing two is, and this is very complicated, so not everyone's going to understand this. Most doctors don't. That's if you start people on one drug or start them on another drug. That's not you.
Right.
You're
Definitely
taking warfarin, and you've been taking warfarin without a complication.
Absolutely.
So there is a good reason to be hesitant to change a winning game, okay? Because whatever complications warfarin can cause, you ain't got them. And Eliquis, actually, it works differently. It has different complications. And so, you know, Bill Tilden, nobody here is old enough to remember Bill Tilden, the great tennis player. He said, and tennis players just don't get it because they're humans. But he said, never change a winning game. Always change a losing game. And we do the wrong thing all the time. If I'm playing really well, I'll say to myself, I should try serve and volley today. So there's many reasons not to change, and it's between you and your doctor.
Great.
And I hope that made sense.
That's perfect. Thank you.
Okay, I think we're out of time, and she doesn't have a cudgel. Last question.
I was just wondering about the frequency that it occurs if you have a one-time thing and it doesn't happen for another year or two or maybe never. Do you take medication? And also, what's the pulse rate? At what point, when it goes up, people's pulse always go up when they're active or whatever. At what point might that be considered AFib?
Well, AFib is an EKG diagnosis. It's not about the rate. And our heart rates and blood pressures go up and down all the time. That's not the same thing as having a high blood pressure. If it goes up when, you know, the Red Sox lose in the ninth inning, that's because you're human and there's nothing wrong with your heart. And you don't have high blood pressure. So it's the same with heart rate. And the first part of your question was...
The frequency that it occurs.
Oh, yeah.
It occurs almost never. I mean,
We play the odds in everything in medicine, okay? And so I thought you were asking, you know, if you've taken an anticoagulant and haven't had a bleeding problem, does that mean your risk is low? No, it doesn't work that way. That's like crossing the street with your eyes closed successfully. That doesn't mean it's safe to cross the street with your eyes closed. And so we try to come up with good ways to estimate risk, and they're absolute not based on experience.
all right, thank you.
All right, we have to stop. Thank you.
This was wonderful.